Every 40 seconds, somewhere in this country, a heart stops working the way it's supposed to. By the time you finish this sentence, another American is having a heart attack. That is roughly 805,000 of them every single year, and almost half of those people will die from the first one before they reach a hospital. Now, here is the part that almost nobody is told clearly enough. In more than half of those cases, the heart was not silent in the days before. It was screaming. Specific signals, lasting minutes or hours, sometimes for days before the main event. The body did exactly what it was built to do. It sent warnings. The person standing in their kitchen, or behind the wheel, or lying awake at 3 in the morning simply was never taught how to read them. If you are over 60, this video is not theoretical for you. The biology is already moving. American Heart Association data shows that men over 65 and women over 65 are the two groups where heart attacks happen most often and where the first event is most likely to be fatal. That is not a reason to panic. That is a reason to learn the 5 signals that come before, because the difference between the people who survive a heart attack and the people who don't is rarely about who had stronger arteries. It is about who recognized the warnings early enough to act inside the window. You know the moments. The fatigue last Tuesday that didn't make sense. You slept 8 hours, you didn't do anything physically demanding, and yet by 2 in the afternoon, you felt like you had been carrying bricks all morning. You blamed it on the weather, the news, your age, the pressure across your chest while you were unloading groceries 3 or 4 seconds, then gone. You stood in the driveway thinking, that was strange, and by the time you walked inside, you had already moved on. The jaw ache last weekend you blamed on the dentist. The nighttime sweat you blamed on the comforter. The breathlessness climbing the stairs that you blamed on getting older. Each one of those moments was a sentence the heart was writing. Most people read none of them until the last sentence is the one that lands them in an emergency room. Subscribe and hit like. There is no billing code in healthcare for prevention that is economics, not malice. And if information like this is going to reach the people who need it, it has to travel through people who share it. We are pushing toward 100,000 subscribers, and every tap of that button helps the next person who needs to hear this find it. Let me explain what a heart attack actually is, because the word gets thrown around so loosely that most people picture something far more dramatic than what usually unfolds. Your heart is a muscle. Like every muscle in your body, it needs its own blood supply. It does not pull oxygen from the blood it is pumping. That blood is busy going somewhere else. It has its own dedicated network of 3 arteries called coronary arteries, branching across the surface of the heart like a tree wrapped around a fist. When one of those arteries gets blocked, the muscle downstream of the blockage starts dying. That is a heart attack. The medical term is myocardial infarction. Myo means muscle, cardial means heart, infarction means tissue death from blocked blood flow. Here is the part that almost nobody understands clearly. Heart attacks do not usually happen because an artery suddenly closes off out of nowhere. They happen because something that has been building inside the artery wall for years finally tears, and a clot forms on top of the tear, and the clot finishes the job. For decades, plaque has been growing inside the wall of one of those coronary arteries. Cholesterol, immune cells, fibrous tissue, calcium, layered into the artery wall like sediment, building up on the inside of a pipe. For most of those years, the plaque is stable. It is sitting there, narrowing the artery without any acute event. Then somewhere along the way, usually after a trigger, like a surge of inflammation, a spike in blood pressure, a stressful event, or a long period of vessel damage, the surface of the plaque erodes or cracks open. Your blood sees that crack the way it would see a cut on your skin. It does what it is biologically programmed to do. It clots. And when a clot forms inside an already narrowed artery, the artery closes. The muscle on the other side starts to die in about 20 to 40 minutes. What matters for this video is what happens in the days, sometimes weeks, before that final clot, because the plaque does not always go from stable to ruptured in a single moment. In a large percentage of cases, the plaque becomes unstable first. It cracks slightly, partially clots, partially clears, cracks again. Each one of those mini events drops blood flow temporarily. Each one of those drops produces a symptom. Then the artery reopens, blood flow returns, the symptom fades, and the person thinks they are fine. In cardiology, this period is called unstable angina, and the precise term for the symptoms during it is prodromal symptoms, meaning symptoms that come before. Research published in the journal Circulation by McSweeney and colleagues, tracking 515 women who survived heart attacks, found that 95% of them had identifiable prodromal symptoms in the weeks before their event. Studies on men show the number is somewhere between 50 and 60%. The window between the first prodromal symptom and the main heart attack is most often 3 to 7 days, sometimes hours, sometimes a couple of weeks. But the pattern is real, it is documented, and it is being missed. That is your window, 3 to 7 days, where a serious cardiac event can still be prevented if the signals are taken seriously. Not panicked over, taken seriously. I want to walk you through the 5 warning signs that show up most often in that window. I'm going to explain not just what each one looks like, but exactly what is happening inside your body when it appears. Because once you understand the mechanism, you can never unsee it again. The first warning sign is a kind of fatigue that does not match what you actually did that day. This is the most common prodromal symptom, particularly in women. The McSweeney research showed about 70% of women reported it in the weeks before their heart attack. It is also common in men, though men tend to dismiss it more aggressively. It is not normal end-of-day tiredness. It is a heavy, draining exhaustion that arrives without explanation. You did not run a marathon. You did not lose sleep. You did the same Tuesday you have done 100 Tuesdays. And by lunchtime, your body feels like it is wearing a lead vest. Here is the mechanism. Your heart muscle, like every muscle, needs more oxygen when it works harder. A healthy coronary artery widens to deliver more blood when demand goes up. A coronary artery with a narrowed plaque cannot widen as much. As long as you are sitting on the couch, you don't notice the heart's resting demand is being met. But when the plaque becomes unstable and the lumen, the open channel inside the artery, narrows even further, suddenly the heart cannot get enough blood for normal daily activity. Walking to the mailbox now requires the heart to pump harder, but the heart itself is partly starving. That mismatch between demand and supply is felt as profound, system-wide fatigue. Think of an engine running on partial fuel. People describe it like this: I had to sit down halfway through making the bed. I couldn't finish the laundry. I felt like I had the flu, but no fever, no cough. If a fatigue like that arrives suddenly, lasts for days, and is out of proportion to what you actually did, that is not normal aging. That is your heart telling you the supply line is failing. The second warning sign is intermittent chest pressure, especially with exertion. I am being precise with the word pressure because most heart attack warnings do not feel like the Hollywood image, the man clutching his chest in agony. The actual sensation people describe most often is heaviness, tightness, fullness, as if someone laid a small weight on the breastbone, as if a belt were tightened across the upper chest. Some describe it as burning, some describe it as indigestion that won't burp out. The location is usually behind the breastbone or slightly to the left of it, but it can sit lower in the upper stomach area, where it gets routinely mistaken for heartburn. The hallmark of prodromal chest pressure is that it comes and it goes. It might appear when you walk uphill, climb stairs, carry groceries, or feel emotional stress, last for 2 to 10 minutes, and then fade when you stop and rest. The next day, it shows up again, perhaps a little easier to trigger this time. The next day, easier still. That descending pattern, where the same activity that used to be fine now produces small chest pressure and the threshold keeps falling, is the textbook description of crescendo angina. It is one of the most reliable warnings the heart can send. The mechanism is the same as the fatigue. A partly blocked coronary artery cannot deliver enough blood for the heart's demand during activity. The brief discomfort is the heart muscle complaining about its own oxygen shortage. The technical term for that complaint is angina. When it is stable, same threshold every time, same intensity, same recovery, it is a chronic condition. When it is changing, happening with less effort, lasting longer, harder to relieve with rest, it is no longer stable, and that is the danger zone. If you have noticed any pressure, tightness, or dull ache behind your breastbone that comes with effort and goes with rest, even if it lasts only a couple of minutes, that signal needs evaluation. Today, not next week. The third warning sign is pain that does not appear where you expect heart pain to appear. The heart has a strange anatomical history. Early in fetal development, the heart and certain other structures share nerve roots before the body fully separates them. Those shared nerve pathways never fully unwire. So when the heart is in trouble, the brain sometimes interprets the pain signal as coming from a different region entirely. Doctors call this referred pain. It is one of the most underappreciated phenomena in cardiology, and it is a major reason heart attacks get missed in emergency rooms because the patient walks in complaining about something other than their chest. The most common referral sites are the left arm, especially the inner side from shoulder down to elbow, the jaw, particularly the lower jaw on the left, the throat, where it can feel like a strange tightness or a lump that won't swallow away, the upper back between the shoulder blades, and the upper abdomen, where it gets confused with indigestion. Women in particular tend to feel referred pain rather than classic chest pain. The American Heart Association's scientific statement on heart attacks in women, published in Circulation in 2016, found that nearly 30% of women experienced upper back or shoulder blade pain in the weeks before a heart attack. About 23% had jaw pain. The character of referred cardiac pain is distinct from a muscular ache. It is usually deep, dull, and not affected by movement or position. If you press on your shoulder blade and the pain doesn't change, that is not the muscle. If you move your jaw and the ache doesn't change, that is not a dental problem. If your indigestion doesn't shift after an antacid and an hour of sitting upright, that is not your stomach. A pattern especially worth recognizing: pain in any of those locations that arrives during physical exertion and goes away with rest. That timing is almost specifically cardiac. Stomach pain doesn't follow that pattern. Muscle pain doesn't follow that pattern. The heart does. The fourth warning sign is shortness of breath that is new, that arrives with mild effort and that does not match your fitness level. You walk up a flight of stairs, you have walked up 1,000 times, and at the top you find yourself out of breath in a way that catches you off guard. You finish making the bed and feel winded. You carry a single bag of groceries from the car and have to stop in the kitchen to catch your breath. You wake up in the night feeling air hungry. None of this fits your usual baseline. The mechanism here is subtle but specific. When the left side of the heart is not getting enough oxygen because of a partly blocked coronary artery, its pumping efficiency drops. Even a small reduction in pumping power causes blood to back up slightly into the lungs. That backup, called pulmonary congestion, makes it slightly harder for oxygen to cross from the lungs into the bloodstream. You don't feel pain, you feel breathlessness. It is the lungs reporting on the heart. Research from the National Heart, Lung, and Blood Institute documents that about 42% of women and a substantial percentage of men report new onset shortness of breath in the days or weeks before a heart attack. Most of them blamed it on weight, on age, on being out of shape. The diagnostic key is novelty. If you have always been winded climbing stairs because you smoked for 30 years, that is your baseline. But if you have a new threshold, if breathlessness shows up at a level of effort that didn't used to bother you, and especially if it shows up alongside any of the other 4 signs, that is the heart speaking, there is one particular pattern worth knowing about: shortness of breath that wakes you in the middle of the night. You sit up, you feel a little better, and you blame anxiety. In cardiology, that symptom has a name: paroxysmal nocturnal dyspnea, and it indicates that lying flat is causing fluid to redistribute toward the lungs because the heart is starting to fail. It is one of the more serious signs in this entire list. The fifth warning sign is the strangest one and the easiest to dismiss. It is a cluster cold sweat, sudden nausea, a sense of unease or dread often arriving together, often at night, often without obvious cause. Picture the moment. You are in your kitchen. You are not exerting yourself. The temperature in the room is normal, and suddenly you feel a wave of cold pass over you. You notice your forehead is wet. Your palms are clammy. You feel slightly nauseated. the way you feel before you vomit, but without any food cause. And underneath all of it is a strange, hard to describe feeling that something is wrong. Patients in the research literature have used phrases like a sense of doom, a feeling I couldn't shake, I just knew something was off. This cluster has a precise mechanism. Your heart is wired into the autonomic nervous system, the part of your nervous system that runs automatically, controlling heart rate, blood pressure, sweating, digestion, and the fight or flight response. When the heart muscle is in distress, those autonomic pathways fire abnormally. Sympathetic nerves activate, dumping adrenaline. Parasympathetic nerves react, slowing digestion and triggering nausea. Sweat glands open. Blood vessels constrict in the skin, producing the cool, clammy sensation. The brain registers the whole storm and translates it into a vague but powerful sense of wrongness, what the cardiology literature actually calls a premonitory feeling. The reason this is so often dismissed is that no single piece of it screams heart. Cold sweats get blamed on hormones, on hot flashes, on a warm room. Nausea gets blamed on something you ate. The sense of dread gets blamed on anxiety. But the combination sweating, nausea, and a feeling that something is wrong arriving together, especially at night, especially without a clear trigger, is one of the most specific cardiac warning patterns there is. The McSweeney research found that nearly half of women experience sleep disturbance in this exact pattern in the month before their heart attack. If you have had an episode like that, especially more than once in a single week, please do not file it under, I had a weird night. File it under, my heart was speaking to me. Now, why does any of this happen at all? Why do plaques become unstable in the first place? Because three forces, running quietly in the background of most lives over 60, are damaging the inner lining of your arteries every single day. The first is chronic inflammation. Inflammation in the medical sense is not the redness from a cut. It is a low-grade, body-wide state where your immune system is constantly slightly activated. The blood marker for it is called high-sensitivity C-reactive protein, abbreviated HSCRP. Research from the Jupiter trial led by Paul Ridker at Harvard and the more recent CANTOS trial published in the New England Journal of Medicine in 2017 showed that elevated HSCRP independently predicts heart attacks, even in people whose cholesterol is normal. Inflammation is what makes a stable plaque unstable. It is the spark that ignites the fuel. The second is insulin resistance. This shows up long before formal diabetes. Your cells stop responding properly to insulin, your blood sugar runs slightly elevated, and your blood vessels are bathed in a fluid that quietly corrodes their inner lining. The endothelium, that microscopically thin layer that coats the inside of every artery and is supposed to be smooth as glass gets scarred, plaques attach to scarred surfaces. The third is chronic stress, specifically the cortisol-driven kind. Cortisol is the long-term stress hormone. When it stays elevated for years from financial pressure, caregiver burden, grief, isolation, it raises blood pressure, increases inflammation, raises blood sugar, and physically narrows arteries by tightening their muscular walls. Loneliness in particular has been shown in multiple large studies to raise heart attack risk by roughly 30%. The body responds to chronic loneliness the same way it responds to chronic physical danger. After 60, two things shift in the cardiac risk picture that are worth knowing. In men, plaque burden is usually well established by this age, and the risk is plaque rupture, that classic crack and clot scenario. In women who were partially protected by estrogen until menopause, the catch-up is rapid. By age 65, women's heart attack rates approach men's. The pattern in women tends more toward plaque erosion rather than rupture, and the symptoms more often present as the atypical pattern fatigue, shortness of breath, jaw pain, rather than the classic crushing chest pain. How old are you? Write your age in the comments. The age distribution of who is watching this directly shapes what I cover next, because someone who is 62 has different priorities than someone who is 78, and I want the next video to be useful for the actual people in this audience. If you have noticed any of those 5 signs in yourself, Even one, even briefly, the first thing to know is that you are not in a position to wait for the next routine appointment. Call your doctor's office today and describe what happened, in plain language in the order it happened. Use the actual words: pressure, fatigue, shortness of breath, jaw pain, cold sweat, sense of dread. Don't soften them. If you are currently experiencing chest pressure that is not relieved by rest within a few minutes, or that pressure is accompanied by sweating, nausea, breathlessness, or pain in the jaw or arm, that is not a wait and see situation. That is a call 911 situation. Standard guidelines from the American Heart Association recommend chewing one full-strength aspirin, 325 milligrams, while waiting for emergency services. If you are not allergic and if your doctor has not told you otherwise, ask your doctor in advance at your next appointment whether aspirin is appropriate for you in that scenario, so you already know the answer if it ever happens. Do not drive yourself to the hospital. If a heart rhythm goes wrong on the way, you are a danger to yourself and everyone else on the road. Have a phone nearby. Have a person you can call who lives close. If you live alone, this is worth planning for now, before the moment arrives. There are 3 tests you can ask about at your next appointment that go far beyond the standard cholesterol panel and that the standard panel will miss. The first is a coronary artery calcium score, abbreviated CAC. It is a quick, low-radiation CT scan of the heart that directly visualizes calcified plaque inside your coronary arteries. The result is a single number your calcium score, and the higher it is, the more plaque is present. A score of 0 means functionally no calcified plaque, and the 10-year heart attack risk is very low. A score above 100 means significant plaque. A score above 400 means high risk regardless of cholesterol numbers. This is the single most predictive test for actual coronary disease that exists, and it is dramatically underused. Greenland and colleagues, writing in the Journal of the American College of Cardiology in 2018, made the case that CAC should be considered for almost every adult over 55 with any cardiovascular risk factors. The second is high-sensitivity C-reactive protein, hsCRP, a simple blood test that measures inflammation. A level under 1 milligram per liter is low risk. Between 1 and 3 is intermediate. Over 3 is high. Most standard panels do not include it. Ask for it by name. The third is lipoprotein(a), written LPA. It is a genetically determined particle in your blood that, when elevated, dramatically raises heart attack risk independent of standard cholesterol. About 1 in 5 people have elevated LPA, and most of them have no idea because doctors almost never order the test. You only need it once in your life. It doesn't change much over time, but knowing the number changes everything about how aggressively you should prevent. The 5 signals: unusual fatigue out of proportion to your day, intermittent chest pressure that comes with effort and goes with rest, pain in the jaw or arm or upper back or upper abdomen, new shortness of breath at a level that didn't used to bother you, and the autonomic storm, cold sweat, nausea, sense of dread arriving together. Any one of them, especially appearing for the first time, especially in someone over 60, is a reason to call a doctor today. 3 to 7 days is the window the research has documented. It is not infinite, and it is not nothing. If your blood pressure is being managed, your blood sugar is being checked, your inflammation is being measured, and you have actually seen what is inside your coronary arteries with a calcium score, then you are not flying blind. You know your terrain. That is the difference between people who get caught off guard and people who don't. Send this to one person, someone you love who is over 60, who you suspect might be ignoring something, someone you can imagine reading these signals and recognizing one of them. You may have just given them the information that nobody else was going to give them. 2 things before you go. First, how old are you? I asked already, but I'm asking again because I genuinely read the comments, and the age distribution of this audience tells me what to make next. 62 and 78 are different videos. And second, where are you watching from? What city, what state, what country? Leave it in the comments. I want to see how far this conversation is reaching because it tells me who needs this information most, and it helps the algorithm understand who else to put it in front of. Subscribe and hit like. We are pushing toward 100,000 subscribers, and if every person watching right now tapped that button, we would be there by tomorrow. The system manages symptoms. It does not always teach you to recognize them in yourself. That is what this channel is for.